This is the Video Journal of Orthopedic Surgery, with our moderator, the professor and chairman of the Department of Orthopedic Surgery at the Medical University of South Carolina, Dr. John B. McGinty.
In this issue of the journal, our speakers are from Dallas, Texas, Dr. Robert W. Buchholz, Associate Professor of Orthopedic Surgery, the University of Texas Health Science Center, Southwestern Medical School. From Rochester, Minnesota, Dr. Kenneth A. Johnson, Associate Professor of Orthopedic Surgery at the Mayo Medical School. From Wilmington, Delaware, Dr. G. Dean McEwen, Medical Director of the Alfred I. DuPont Institute. And from Los Angeles, California, Dr. Edgar G. Dawson, Professor of Orthopedic Surgery at the University of California, Los Angeles School of Medicine. We begin with Dr. Dawson, who will discuss spinal stenosis. In the recent past, there's been a tendency to relate low back pain to narrowing of the lumbar canal. Can spinal stenosis really be a cause of low back pain?
With the advent of CT scanning, spinal stenosis has become a very popular diagnosis. The condition has probably been around for thousands of years, but we've really not had a very good way to establish the diagnosis. And I think a lot of things that in the old days were called arthritis or lumbago or any number of other conditions were actually probably spinal stenosis. With the advent of CT scanning and more interest in this condition, we've learned a lot about it. Currently, it's classified into causes. We have the congenital or developmental causes, which are primarily idiopathic or achondroplastic. Then we have the acquired causes. Acquired means that it is not present at birth, but develops sometime throughout the life of the patient. Those particular types that we see are degenerative, combined, spondylolithic, iatrogenic, post-traumatic, and a variety of miscellaneous causes. In thinking about the patient that has spinal stenosis and trying to formulate a treatment plan, I think that you're going to encounter most often degenerative spondylolisthesis. And you should look at it anatomically rather than etiologically in trying to figure out what to do and what's causing the symptoms. In degenerative stenosis, we have central canal stenosis, which is narrowing primarily the central canal, lateral recess stenosis, foraminal stenosis, or more commonly, combinations of any of the above three, and then we have degenerative spondylolisthesis. The combined type of stenosis is either congenital or acquired stenosis with a superimposed herniation of an intervertebral disc, which leads to the onset of the patient's complaints of back and or leg pain. We really need to look at the anatomic basis for lumbar stenosis before proceeding onward. If we take a look at the lateral aspect of a normal spine, we can see a number of anatomic factors that, if altered, could conceivably narrow the spinal canal and cause spinal stenosis. If this particular intervertebral disc was to narrow, you would get bulging here of the posterior annulus and the posterior longitudinal ligament, causing narrowing from the anterior aspect of the canal. In between this lamina and this lamina is the ligamentum flavum. It is highly elastic, and it's under some stretch in the normal position. As the space narrows between two adjacent vertebral bodies, so the disc narrows, the ligamentum flavum has to shorten. Because it's elastic, as it shortens, it thickens. This will cause some narrowing from the posterior aspect of the canal. Also, right at this point is a nerve root exiting. As this nerve root exits, it goes out directly underneath the pedicle, so that anything in this foramen, such as an osteophyte arising from here that grows into the foramen, can cause stenosis, and therefore the patient will ultimately present with symptoms of nerve compression. If we take a look at an anatomic specimen that looks exactly like a CT scan, you'll notice here the vertebral body. Here is the posterior part of the annulus. Notice the facet joint. And see, here is the ligamentum flavum, which forms the medial capsule of the facet joint. And right here in this area is the nerve root. If something happens to these joints where the articular surface gets worn and they slide together, the ligamentum flavum is going to bulge inward in this direction, and as it does, it's going to cause compression of the underlying neural elements. At the level of the foramen, there is even more of a problem with this ligamentum flavum on this side and on the opposite side, where you can see it actually begins to encroach on the foramen. Again, if something happens to this where it begins to change in size or shape, you're going to have nerve root compression. In addition, right at this point, posterolateral aspect of the annulus, where the forces acting on it are the highest of all of the annulus and the nucleus, if this thickens or herniates outward, again, you will have an anvil hammer effect where you can have compression of a nerve root here from something coming from posterior and from something coming anterior, hence foraminal stenosis. As stenosis occurs, it will cause compression of the dura and the underlying neural elements. And generally, that's what causes the patient's symptoms. A variety of types of stenosis can occur based on the anatomic changes that occur in the spine. If you have laminar compression, you will see a generalized narrowing of the dural tube. This is fairly commonly seen in congenital stenosis. It's interesting, in fact, that if you relieve the bony stenosis in congenital stenosis, the dural stenosis will remain relatively unchanged. Several other things can happen. If the disc narrows, the two adjacent vertebrae get closer together, and as the pedicle slides caudally, it can kink the nerve root at this point, causing a lateral stenosis. And with further time, if the ligamentum flavum or the facets become hypertrophied, you can have subarticular entrapment of the nerve root with narrowing and, again, symptoms. This is best seen in this circumstance where you have subarticular entrapment before the nerve gets to the pedicle due to arthritic changes in the facets, thickening of the ligamentum flavum, and in addition, as this pedicle settles, and you'll notice here that the facets are incongruous at this point, this pedicle will cause compression of the nerve at this point. Osteophytes are causing compression at this point. And finally, right out at the foramen, the superior articular process of the vertebra below is causing, again, another point of compression, giving you a variety of types of stenosis. As I mentioned, spinal stenosis has become a fairly common and popular diagnosis with the advent of CT scanning. CT scanning is our most reliable tool in the recognition of this particular condition. Here is a typical example of a CT scan of a patient who has rather classic central canal stenosis. Notice the typical trifoil picture here with marked narrowing in all dimensions, anterior, posterior, and medial lateral. In addition to the central stenosis, the next type we have is lateral recess stenosis. You can have a very wide open lateral recess here, and due to an osteophyte in the opposite facet joint, you see rather dramatic occlusion of the opposite lateral recess, and this is a classic unilateral lateral recess stenosis. More typically, however, you see bilateral lateral recess stenosis. Notice that the central canal is fairly well preserved. Notice as you get out into the lateral recesses, due to enlargement of the articular process and ligamentum flavum, that there's almost no room at this point and no room at this point for a nerve root to exit, hence lateral recess stenosis. The only good way to identify foraminal stenosis is with CT scanning with sagittal reconstruction. And in this example that you see here, you can see a large osteophyte occluding the foramen at this point and another large osteophyte occluding the foramen at this point. These are very difficult to identify with anything other than this sagittal reconstruction of CT scanning. What are the clinical features of lumbar spinal stenosis, and how do they differ from the patient with herniated intervertebral disc, which is the most common alternate diagnosis in patients that present to us with back pain and leg pain. First is age of onset. Herniated discs generally present prior to the age of 40, and the patient with lumbar stenosis becomes symptomatic usually over the age of 50. Herniated disc is more common in male to female by about 1.5 to 1. In stenosis, it's a bit more common in the males, 2.1 to 1, male to female ratio, except in congenital stenosis, where the ratio is 8 males per 1 female, so it's almost exclusively a male disease. Backache as a presenting complaint is acute in patients with herniated discs and chronic long-standing in patients that have spinal stenosis. On examining the patient, straight leg raising is usually limited in patients with herniated discs and unlimited in patients with stenosis. Only 20% of patients with herniated lumbar discs will present with bilateral leg complaints, whereas a full 1/3 of those patients with lumbar stenosis will have bilateral leg complaints. Normal radiographs are common in the patient with disc herniation, and they are rare, if not impossible, in the patient with stenosis. One rather unique feature, which is almost pathognomonic to lumbar stenosis, is the fact that their symptoms of leg pain are often relieved by lumbar flexion, and that is rare in the patient that has a herniated disc to have lumbar flexion relieve their symptoms. Single-level disease is common in disc herniation and rare in stenosis. Usually you have at least 2 levels involved in lumbar stenosis. The most common areas that you see involved are L4 and L5. So to establish the diagnosis of lumbar stenosis, you should have a history consistent with the diagnosis. The age of the patient, generally over the age of 50. Duration of symptoms, long-term, chronic. Often these patients will present with pseudoclaudication. They will be able to walk 50 or 100 yards, and then they will get a cramping buttock and calf pain, which is relieved by either forward bending at the waist to flex the lumbar spine or relieved by resting. And then the symptoms will go away and the patient can walk another 50 to 100 yards. This is called pseudoclaudication because true claudication is caused by vascular ischemia of the muscles of the legs, and this particular condition is not. Historically, the patient will usually have bilaterality of symptoms, and often they will complain of pain, or more often, surprisingly, a sense of numbness or heaviness in the legs that is quite typical of this condition and not so typical of anything else. And as I mentioned before, relief of leg pain with lumbar flexion is fairly common. On physical examination, the patient with stenosis, you will see a relative lack of neurologic deficit, except that loss of reflexes, particularly the ankle reflexes, is quite common bilaterally. They usually have a very stiff lumbar spine, and they have normal peripheral pulses. This is to help you distinguish it between that and true claudication of the patient with peripheral vascular disease. Electromyography may not be that helpful in finally giving you the diagnosis, but if you're going to use it, you will usually find bilateral and multi-level pathology with denervation in multiple levels rather than a single level, which would be more consistent with acute lumbar disc herniation and not with stenosis. There are a number of radiographic studies available to us to establish the correct diagnosis of lumbar spinal stenosis. Conventional radiographs are extremely useful. If a patient has absolutely normal radiographs, the likelihood of stenosis being the diagnosis is almost impossible. Computerized axial tomography is the standard. This has allowed us to really get into the correct diagnosis and develop better treatment protocols. Water-soluble contrast myelography is probably indicated in every patient where a consideration of surgical decompression is being entertained. Magnetic resonance imaging will probably replace many of these above-mentioned radiographic studies. However, it's too new to really know its role in the management of and diagnosis of lumbar stenosis at this time. Conventional radiographs show us a great deal. We can see on an AP radiograph evidence of degenerative changes in the facets, which will give us a clue that there's a possibility of lateral recess stenosis. And on a conventional lateral radiograph, we may see just the beginning of degenerative spondylolisthesis, which again is going to possibly lead to spinal stenosis. The CT scans are extremely helpful. Not only do you get a good look at the central canal and the nerve roots with CT scanning, but you can also get a good look at the lateral recesses in these areas, and here you can see that these are actually quite narrowed. Myelography, in particular water-soluble contrast myelography today, it seems to be extremely useful in giving you additional information. Many clinicians now will use a combination of water-soluble contrast myelography simultaneously with CT scanning to develop the maximum amount of information. I think this is probably a good idea. Notice here with water-soluble contrast myelography a waistline constriction in the dye column compared to above and below. And notice on the oblique of the myelogram there's an indentation. This is quite consistent with central canal stenosis. On the lateral radiographs with myelography, sometimes you can see actual pathology presenting with an indentation from the posterior aspect of the vertebral body into the dye column, causing compression and stenosis. These myelograms can give you a lot more information than just the anatomy. They can really alert you to potential danger. This particular myelogram shows a two-level block, starting here and extending to here. And if you look at the oblique film, you'll notice that you can see the cauda equina standing out quite clearly. Notice that there's a high degree of block at this point. Findings such as this on myelography should alert you to the possibility of a very thin dura and the risk of cauda equina herniation out of a small hole in the dura at the time of your surgical decompression. So make sure you see that and be extra careful in that particular patient when doing your surgical procedure on or near the dura. Another thing that myelography is useful for is giving you the extent of disease. This particular patient has Paget's disease, and the pagetoid bone has enlarged and caused a long, long area of stenosis with extremely narrow dura here at this point and almost non-existent dura here at this point. CT scanning, it would be very difficult for you to know the full extent of the condition, and I think here you would have to do a much more extensive operation than CT scanning would indicate. So I think that in many of these cases, myelography really dictates the nature of the procedure that you plan. What about treatment for spinal stenosis? Basically, we have non-surgical and surgical treatment. Non-surgical treatment should consist of bed rest, appropriate prescribing of non-steroidal anti-inflammatory agents, weight loss, reconditioning, and sometimes the application of an external orthosis. The problem with using a corset or a brace, however, is that many of these patients are older and will not tolerate any type of an external orthosis. If we can't get them better non-surgically, what can we offer? We can offer surgical treatment. If the patient has only central stenosis, laminectomy is probably adequate. If they have lateral recess stenosis, laminectomy plus medial facetectomy, with ensuring yourself that you have not only removed the medial facet, but also the ligamentum flavum causing that root compression, is the appropriate operation. If the patient has foraminal stenosis, then you must do a foraminotomy as well as the above other two procedures. In the patient that has symptomatic degenerative spondylolisthesis with stenosis from it, then the above decompression plus a lateral or intertransverse fusion is the appropriate surgical management of degenerative spondylolisthesis. What kind of results can we expect in operative treatment or non-operative treatment of spinal stenosis? With non-operative treatment, the patient with congenital spinal stenosis will have good results 50% of the time and poor results 50% of the time. In the acquired stenosis, good results are seen in only 20% of patients. Hence, 80% you can expect to do fairly poorly with the non-operative treatment regimen. With appropriate surgical treatment, and appropriate means adequate decompression and stabilization if necessary. With congenital stenosis, the good results are 70%. In acquired stenosis, with localized disease, 1 or 2 segments, good results are expected in 85% of patients. And with diffuse or multi-level disease, more than 1 or 2 segments, about 60% will get good results with appropriate surgical decompression. What happens to those patients that fail, and why do they fail? Causes of failure of surgical treatment are inadequate preoperative assessment, where we've missed anatomic factors such as lateral recess stenosis or missed foraminal stenosis because we did not have a CT scan with sagittal reconstruction, or we've had an inaccurate diagnosis. Patient has peripheral vascular disease with significant atherosclerosis, or they have a metabolic neuropathy such as diabetic neuropathy, and what we have been assuming to be symptoms of numbness and or claudication based on stenosis is in fact due to another cause. Causes of failure of surgical treatment most frequently is an inadequate operation has been performed. Either complete decompression was not accomplished, or iatrogenic instability was not recognized and treated appropriately by arthrodesis, or not infrequently the pathology was too extensive for any surgical procedure. And lastly, we must remember that there are some failures based on the inadequate patient. Psychological and secondary gain factors were not properly evaluated prior to recommending an operative procedure. When the operative procedure is performed, you must make sure, when you're doing the procedure, that the decompression appropriately in the lateral recess and foraminal stenosis cases gets far enough lateral to achieve the goal of decompression. Notice the nerve root here is decompressed, and notice that a major part of the medial facet is removed. Over here, see how much hangs over that nerve root, so that when you're completed with your operation, you should have this much bone left and a complete release of the nerve root laterally in order to achieve a good surgical result. On CT scanning, after an appropriate surgical procedure, you should see something that looks much like this. We'll look at it a bit closer. And here is an intact lateral recessed non-stenotic. Here is one that is appropriately surgically decompressed. Notice it comes right out to the lateral extent of the canal. And finally, in order to make sure that the foramina is open, oftentimes intraoperative probing of the foramen will not give you the answer. You should have had that answer ahead of time. And here with the sagittal reconstructions, if you see this type of a lesion or this type of a lesion present on CT scanning, you must plan at the time of your procedure to do a foraminotomy. In conclusion, lumbar spinal stenosis, as we know it, is primarily a surgically treatable condition. An adequate pre-surgical evaluation is essential for good surgical results. You must not do a surgical procedure on a patient whose symptoms are being caused by peripheral vascular disease. You must not do a surgical procedure on a patient who has such extensive disease that no operative procedure can benefit them. I think, however, that if you do as recommended and go ahead with the proper evaluation of the patient, you can, in the most common type, the degenerative type of stenosis that's acquired, with proper and careful patient evaluation pre-surgically, that 85% of your patients will have good results.
Ed, how long do you keep a patient on non-surgical treatment before submitting him to surgical decompression?
Well, I think that most patients probably ought to have at least 3 months of non-operative treatment unless they have the situation where you're beginning to see progressive neurologic deficit. The other thing that would push you to violate that 3-month time frame, I think, is probably the patient has rather severe pain that's not being controlled well with other than high-dose narcotics.
How long does it take after surgery for a patient to be relieved of his symptoms? And what is the rate of recurrence of symptoms, Ed?
Well, I think that if the patient's symptoms are all coming from the stenosis, they should be relieved of their symptoms within a couple of days. It's not like the patient with chronic nerve compression after disc problems where it may be several months before you see the maximum benefit of the procedure. In fact, I think I'd be fairly discouraged if my patient, by the time they're ambulatory at 3 or 4 days, isn't completely free of leg pain. As far as the problem of how often you get recurrence, very rare, because this is a condition that takes decades to develop, and most patients are in the older age group by the time they get it. However, in patients that have degenerative spondylolisthesis, if a fusion isn't done, they may slip further, and a recurrence rate could be fairly high.
What type of spinal stenosis gives the best prognosis after surgical decompression?
I think that the best prognosis is in the patients that have 1 or 2 level disease in the acquired degenerative type of stenosis. 85% of those patients will be better with appropriate surgical decompression.
In patients with spinal stenosis in which you performed a decompression, in what group of patients do you add a spinal fusion?
Patients that have degenerative spondylolisthesis surely will slip more after adequate decompression and should have a lateral or intertransverse process fusion. In addition, if you see the patient has major resection of the facets and you've created iatrogenic instability, then you better do a fusion. Otherwise, you're going to end up with a problem of degenerative spondylolisthesis sometime in the postoperative period.
What's the most common error, Ed, that a surgeon can get into when he decompresses for spinal stenosis?
Well, probably the most common intraoperative error is inadequate lateral recess decompression. You really have to get all the way down to the pedicle and make sure that almost all of the medial aspect of the facet is removed. Don't be satisfied that you've done an adequate decompression until you can follow the nerve root all the way out from its exit from the dura until it disappears out under the pedicle. And don't be satisfied with just seeing the medial half of it.
Is a complete block on myelogram always an indication for surgical decompression?
No, I don't think it is. The mere presence of a myelographic block is not a sine qua non that an operation is necessary. A patient who has progressive neurologic deficit or intractable pain has those indications for the operation, so that just a myelographic block is certainly not a reason to justify an operation such as laminectomy.
What do you do, Ed, with the patient that has spinal stenosis and also has a ruptured intervertebral disc?
This group of patients is probably the most difficult to treat. You have a narrow canal and you also have a relatively recent insult anteriorly due to protrusion of a disc into a stenotic area. These patients are at risk for rapid deterioration neurologically. Chymopapine is not indicated. In fact, it's contraindicated in these conditions. But most of these patients need rather early surgical decompression. And in addition to the formal decompression of the stenosis, intervertebral disc excision should also be included as part of the operation.
Thank you, Dr. Dawson. Dr. Dean McEwen will discuss Legg-Perthes disease. The painful hip has been a problem to the orthopedic surgeon for a long time, particularly as far as the predictability of outcome. Dean, can you bring us up to date on the management and evaluation of Legg-Perthes disease?
Jack, there's been a great change in the treatment of Perthes disease in the last 30 years. When I first entered the field in the 1950s, the treatment was completely conservative. And as time has gone along, the surgical methods that were developed for congenital dislocation of the hip tended to be used in the treatment of Perthes. This caused some confusion and a reevaluation of the total problem. As time has progressed, it's become apparent that there is indications for conservative therapy and also some surgical indications. At the Alfred I. DuPont Institute, we've had a large opportunity to evaluate the children with Perthes disease and have been able to follow many, at least 150, to skeletal maturity. This has given us an opportunity to evaluate the problem in more detail. The best method to evaluate the end result has been that method developed by Mohs, developed in Denmark, where a series of concentric circles are developed which are 2 millimeters apart. If at the time of the finish of treatment the femoral head is completely round in both the AP and lateral view, an excellent result is expected and a classification of excellent is developed. If the femoral head is 2 millimeters off, then this is considered a fair result, and if the femoral head does not fit in 2 millimeters, it is considered a poor result. This is a very demanding technique, but it's been quite an easy method to use by many people in the field. A classification has also been of help, and that was developed by Catterall in the years past, and this shows a classification of 4 types of Perthes. The group 1 is that where there's a very small defect in the femoral head, which shows mainly on the lateral view, and on the anteroposterior view shows no real defect in the subchondral area. In this, one can anticipate an excellent result. In the group 2, on the lateral view, there is a definite defect in the epiphysis, which as a rule does not extend beyond the epiphyseal line or only to a very small degree. And on the anteroposterior view shows as more of a notching in the top of the femoral head. This again will produce a very satisfactory result, as shown in this patient, which at 19 has essentially a normal hip. In the group 3, where there's a significant involvement of the femoral head, it shows not only on the anteroposterior view as a large defect on the top of the head, but on the lateral view shows that the defect is even larger and extends across the epiphyseal line into the metaphysis. The metaphyseal involvement on the lateral view is very helpful in classifying patients into this group 3. Group 3 means that there's been a significant involvement of the femoral head, and at the end result, as shown in this same patient at skeletal maturity, some deformity is to be expected. And these patients rarely end up, by matter of what method is used, with an excellent result. In the group 4, there's essentially a total involvement of the epiphysis on both the anteroposterior and lateral views, as shown in this patient here. And again, this produces, as a rule, less than a completely satisfactory result by any method. It is unusual to see this type 4, however, and most of them are either a type 2 or a type 3. The Catterall classification has been very helpful in making somewhat of an analysis of the amount of the femoral head involved, and has been very helpful to look back in retrospect to see how much of the epiphysis was involved and whether the treatment could be stopped at an early phase. The summary of the Catterall classification can be shown where there's less than 50% involved or where there's more than 50% involved. And in this summary, if less than 50% is involved, one can anticipate a good result if never more than 50% of the femoral head is involved. Whereas if more than 50% of the head is involved, this will almost certainly require treatment and has some concern for the end result to be expected. So for most practical purposes, it is enough to divide the femoral head into whether less than 50% is involved or more than 50% is involved. However, there are other things that are equally important, and in some cases more important than in strictly the classification of the amount of femoral head involved. Probably the most important thing is the loss of motion. If there is a significant loss of motion in the hip, and if this persists, this is a bad omen and will almost certainly result in problems. And therefore, it's important to regain the motion in the child with Perthes and to maintain this motion. And if later the motion is again restricted, it's important to regain it to obtain a good result. Also, metaphyseal cysts are important. If there is a cyst in the metaphysis, even if the epiphysis looks to be in good condition, this is a sign that there is involvement of the epiphysis over this area of cyst. And if there's a large band that crosses the whole of the metaphysis, it's usually a sign that there's a major involvement of the femoral head. Also, the early lysis of the lateral portion of the femoral head has been important. And when this shows up as a large defect that can be at the epiphyseal line and the metaphysis, it's a sign that there is not only a biological concern in this area, but also a mechanical concern because of the lack of strength to support the epiphysis in this area. And it's a sign that vigorous treatment and containment is necessary, as is shown in this same patient, where this area filled in, but filled in relatively in a round condition because the hip was maintained in abduction during the time that this was reconstituting. Also, similarly, the lysis of the subchondral area, as was shown by Caffey many years ago and popularized by Salter, showing if there's lysis of the subchondral bone in the femoral head, that there is involvement of the epiphysis almost certainly in the area of this lysis. Unfortunately, this only shows in approximately 25 to 30% of the regular x-rays that have been taken. With special views, it is possible to demonstrate it more clearly, but the average views that are taken do not help a great deal with this test in many cases. When it's present, it's helpful, but when it's not, it does not mean that the femoral head is in good condition. The next problem is that of subluxation extrusion. In the problem of congenital dislocation of the hip, one of the major problems is that of subluxation, where the femoral head is not deeply seated in the acetabulum. However, in Perthes, as has recently been shown, particularly in doing arthrograms, as a rule, the femoral head is not unstable inside the joint. And that much more attention must be paid to that of extrusion, where the lateral part of the femoral head is the area that needs to be paid attention to, rather than medially, as is shown in this same patient 2 years later, where there's a large defect and a big problem in the lateral part of the head. There may be some widening medially, but this is not instability. It is much more a problem of extrusion of the head in the lateral portion. This is even more clearly demonstrated in this 4-year and 6-month-old female who has a large femoral head with extrusion and some subluxation, who at 8 years of age shows that the extrusion and the catching laterally is much more important than the actual subluxation at the inner part. So we have to think more of the lateral half of the femoral head than we do in congenital dislocation of the hip. Another problem is that of lateral calcification. Catterall and others have felt that this was an earlier sign showing that the head was at risk for later problems. However, one should recognize that if there is even small flecks of ossification or calcification lateral to the epiphysis, this suggests that there is already enlargement of the model and that this is a late sign rather than an earlier sign. Once this has occurred, the head is larger than it's expected to be, and it means that one will end up with a large head that's either flat or round. At 8 years of age, in the same patient, shows that the head is relatively round because the hip was maintained in a containment process during part of the interval. However, if containment had not been maintained part of this time, the head might well have been completely flat rather than round. And the lateral calcification is a sign for active treatment. It, however, shows that the process has been going on for some time, and it's very important because to have a large femoral head is not particularly a deficit if it's round, but it's important that it be round, as is some anticipation in this particular patient. The last of this group is that of involvement of the growth plate. For many years, we felt that the growth plate was not a significant concern during Perthes, but it is a real concern, as shown in this patient who's 10 years of age, who has been through most of the process of Perthes, but is showing that the neck is already short and there's a large divot out of the head in the lateral view that crosses the epiphyseal line. Both of these suggest that the epiphyseal line has been completely closed and there's no further growth. And if there's no further growth, there's very little possibility of reconstitution and reshaping of the head if there's a real loss of growth in the epiphysis. And this is the same patient at 20 years of age, showing that there's been no further growth of the femoral neck, and there's been no real remodeling. And so that if there's a complete closure of the epiphyseal line in Perthes, while the process is still going on, it will end up with a poor result, no matter what has been determined. It is also at times the involvement of the epiphyseal line may be lateral, as is shown here, and in this particular patient, which went through the process early and looked to have a very good result. By age 9 is showing some change, and at skeletal maturity shows that there's been an alteration in alignment of the head on the neck into valgus, and there's been a shortening as a result of the involvement of the growth plate. So we've learned that approximately 25% to 27% of these patients have an involvement of the growth plate to at least some degree. And if this occurs, we realize that the involvement of the growth plate not only decreases the potential for growth and remodeling, but it means that there's been a very serious involvement of the femoral head. There's no accurate way to make the determination of the involvement of the growth plate in the early stages. Hopefully, with radioactive isotopes in the future, this may be possible. But at the moment, It does not help the individual child to have this analysis at this time. The process of treatment is that really of two types. Many times in the past, the treatment of Perthes has been lumped into one group, but can easily be divided into early and late. And therefore, a patient like this, at 7 years of age, who has a very early involvement of the epiphysis, is a different process and it needs a different treatment program than one that comes late, that has already significant deformity of the femoral head and even an alteration at times in the epiphysis with overgrowth and extrusion. And I think it's very important to separate these two into different groups and to consider them as different processes. So the aim of treatment is really that, to obtain and maintain a range of motion and to maintain the femoral head deeply placed within the acetabulum. The motion can be obtained by either putting the child in bed with or without traction. The traction per se is not that important, but even motion with bed rest is important at times. So anything that puts the child off the hip to regain the motion is very important in the early phase. The containment is an important consideration. First of all, in the early stages of the condition, to prevent deformity by holding the femoral head deep within the acetabulum. In the cases that come later, containment can also be important in an effort to remodel a hip that's already shown some deformity. However, this has been a change in philosophy as regards containment in the past number of years. In the early stages of our program, we did not use containment, but changed over to a containment program in the mid-60s. Without containment, we ended up with 33% poor results, and by a containment program, even though the numbers were somewhat smaller, we're able to reduce the ones that ended up in the poor category by the method of Mohs to 16%. It is true there's been some change between the good and the fair, but that's probably because of a more aggressive program with the containment group. But it does appear that containment is a definite consideration, especially in the early aspects of the treatment of Perthes, to try to prevent deformity. This is the X-ray of a patient showing an effort at containment. However, the containment is not adequate in that the lateral part of the epiphysis still has the possibility for extrusion out of the acetabulum. And it's therefore very important to produce more complete abduction so that the lateral part of the epiphyseal line approximates the corner of the acetabulum to prevent further extrusion. So what is the methods that are available for the treatment of Perthes? What is the method to treat this young man who has been limping only for a very short period of time? And what is the best method to handle such a problem when it's recognized in the early part of the condition? Radioactive isotope studies can be helpful at times to differentiate between synovitis versus Perthes, but many times a few days of bed rest will help make this determination without using this sophisticated method. There have been many methods used for the treatment of Perthes in a non-operative fashion over the past years. Many years ago, the standard treatment was a so-called ischial weight-bearing brace, where the weight was supposedly taken over the ischium, but this has not proven satisfactory. It has not been able to produce the pressure through here. It has no containment potential whatsoever, and at times can actually lever the femoral head out of the acetabulum. So this is not an adequate method. The other was the different methods of slings and crutches, but again, it does not produce containment, and it also counts on the child to do the appropriate non-weight-bearing function, which the child does not do. So it is not a method to be used to any degree. If the child has been limping for only a few days, is somewhat older, the diagnosis is not definite, it can be a technique to relieve pressure on the hip for a short period of time, but it is not adequate treatment when a definite Perthes exists that requires care. The first method of treatment for containment that worked very well was that developed by the late Dr. Petrie of Montreal, where 2 casts were applied and kept in abduction, which kept the femoral heads well centered. This was also produced by Harrison of England at approximately the same time. This produced quite satisfactory results and produced a very adequate method of containment. However, it was rather difficult, and therefore methods were developed to replace the plaster with different types of materials, such as this method from Toronto with the metal and plastic. Dr. Roberts from New Orleans developed a technique using leather and metal, and then gradually it became apparent that there was not the need for internal rotation, which had been previously thought, because antiversion is not a significant problem in Perthes. And therefore, Dr. Lovell from the Scottish Rite Hospital in Atlanta developed the short brace, which would maintain abduction but not control rotation. However, the child does walk in flexion with this technique, and therefore by this does produce covering of the anterior part of the femoral head. So it would appear at this time that this is the most acceptable non-operative method. It's a simple method, and the child can do many things, and it produces a result essentially the same as other techniques. However, it is very important to obtain a standing X-ray in the device with the child in the treatment program, because if the femoral head is not covered while in the device, it may actually be acting as a wrong technique, because it can produce pressure here and increase the risk of extrusion. So the X-ray should be obtained, and if it's not adequate, further abduction must be produced to maintain the femoral head deep within the acetabulum to get the appropriate result, as is shown in this patient, where it has been abducted further, and then the lateral part of the epiphyseal line approximates the lateral corner of the acetabulum to hold the femoral head deep within the acetabulum. One part that's very important is that the patient should be examined out of the brace each time that they return for care. It is not adequate just to look at the brace and see how the brace is doing, as there is a tendency to do, but the child should be removed from the device to be certain that the motion has been maintained. If the motion is not maintained, the child should be returned to a period of traction, either full-time if there is a significant loss of motion, or on a part-time basis, such as using traction at home at night if it's only a relatively minor change in loss of motion. So the important things in the treatment is to maintain that contained deeply in the acetabulum and to maintain the range of motion. And with this method, as a rule, one can anticipate a good result. There's also the problem of determining how much of the femoral head is involved. It was thought at first that this would be a relatively easy task to determine this. And in a patient such as this, where there's only the defect in the middle part of the head and there's a strong lateral column, it's apparent that there is relatively small portion of the femoral head involved, and this is at most a cateral 2. And this patient later shows that the head is recovered and is done very well. And this would occur with or without treatment. The big question, though, is to determine early, if possible, how much of the femoral head is involved, so that if less than 50% is involved, treatment can be discontinued or not started in the first place. Radioactive isotopes may in the future be of help in making this determination. But in most parts of the country at this moment, this technology is not advanced to the stage to allow this evaluation. So in this patient at 7 years of age with the early stage of Perthes, it's very difficult to determine how much of the femoral head is involved. By 3 months later, it would appear that most of the femoral head is involved. But if one waits for a total of 7 months, it shows that the lateral column of the femoral head was intact all the time, and this was a cateral 2. It would appear in most patients that it requires approximately 6 months from the onset of the condition to make an accurate determination of how much of the femoral head is involved. The question then comes up, should one treat the patient while waiting for this interval? It is my feeling that they probably should be treated if there's any concern, and especially if there's been an early significant loss of motion. Because it's very difficult to make this final determination, and if one waits too long, one will see the lateral calcification or the extrusion, which means that deformity has already occurred. So my preference is to treat most of them in the early stages and remove them from the treatment program as soon as it becomes apparent that they're less than 50%. If they're more than 50%, they should be continued on into the treatment program. The question has always been also as to when the brace treatment should be discontinued. In the past, the tendency was to wait till the subchondral bone plate was reconstituted in both the anteroposterior and lateral views on the röntgenograms. However, in many patients, this required at least 2 years, sometimes 3 years, which made the treatment very protracted and very unappealing. However, as time has gone along, it's been apparent that there may be a need to reconsider this problem. This is a patient of 8 years and 4 months who's well into the problem of Perthes and halfway through the reconstitution phase. He discontinued his treatment at this time and came back at age 23 for our review of the general patients. To our surprise, we discovered that he had essentially normal femoral head and growth had continued in a normal way. And it does appear that one can discontinue the treatment program much earlier than we used to think if the head is relatively round and as soon as the dense bone has gone out of the femoral head. If the sclerotic bone has disappeared, then, and the motion is maintained and the head is relatively round, one can discontinue the treatment in a much earlier phase than we previously thought and can hope for results similar to this. This usually means that the treatment can be discontinued in approximately 12 to 14 months from the onset of the condition. So in the average patient, if it takes 6 months to make a determination of how much of the femoral head is to be involved, and if one can discontinue the brace treatment in the most significant deformity at 12 to 14 months, it makes the non-operative method rather compatible and a good technique to be considered rather than going to surgery just because the treatment may take a long time. So in summary for this, if the motion is maintained and the deformity is not severe, usually one can discontinue the treatment within 12 to 14 months. Surgery can also be considered in the treatment of Perthes. Again, this can be thought of in 2 areas. One is an alternate to the early treatment to maintain containment in a child that does not have deformity. It is secondarily to be considered in the reconstructive phase where a deformity has already existed and an effort is being made to reverse this deformity. In the alternate method for the early treatment, the surgical method is that to produce containment by a surgical method of its own. An example of this is a 6-year-old male with bilateral Perthes who could not be contained in a brace because of his attitudes and his social considerations. And it was felt that since he was centered well on abduction views, that bilateral varus osteotomies could be done and were done, which showed a very satisfactory result in follow-up in that both femoral heads are well seated into the acetabulae. The angle of the osteotomy should not be reduced to approximately 90 degrees. It should only be reduced to a low normal of 110 to 115 degrees, because if it's reduced down to approximately 90 degrees and there's an involvement of the epiphyseal line, the hip will not remodel and a second osteotomy will be necessary. This is a follow-up at 12 years of age showing a most satisfactory result. If internal fixation is used on this type of procedure, as a rule, some type of technique that can be screwed into the side of the femoral neck and head is more important than some mechanical device that must be hammered in because of the problem of softening of the femoral head. Another method that's been developed to produce containment of the femoral head has been the method of Dr. Salters that was developed for congenital dislocation of the hip. If the femoral head is significantly involved and on the abduction view can still be placed deeply in the acetabulum, then an osteotomy can be considered across the pelvis that can contain the femoral head to a greater degree. There is considerations for both techniques. The experience of the surgeon is very important. Some people have had more experience working on the femur than on the acetabular area, and some have had the opposite. So this is very important in the consideration. The motion is very important. If there's been any significant tendency to restriction in motion, then the femoral osteotomy seems to produce less stiffness in the postoperative phase. And certainly if there's restriction, Salter's procedure should not be considered during the restrictive phase. Leg length inequality is a consideration. If for some reason, either from this process or otherwise, the leg is already short, then a femoral osteotomy will aggravate the problem, and where the Salter procedure might be beneficial in restoring to some degree. The total considerations of the treatment of Perthes in the early phases as an analysis shows that there is not a great deal of difference in any of the methods that we've outlined. It is possible by any procedure that is satisfactorily carried out to produce approximately the same results, with approximately 25% ending up with less than an ideal result. So the choice between the treatments is sometimes the experience of the person, the availability of braces or surgery, and also to some degree the attitude of the family, the patient, and the physician involved. So it would appear that any one method can be helpful if it's carried out in a satisfactory way. It is my own feeling that in the non-operative method it takes approximately 6 months to make complete diagnosis, and if the bracing can be discontinued at approximately a year, that this is often and most times a treatment of choice in the average patient. The treatment then moves on to the late condition, as to the person that already has a deformity, where the acetabulum may even be involved, and there's lateral extrusion of the femoral head. And I think it's important that this be considered differently and in a completely different light than the patient that just had the symptoms for a short period of time and does not already have this deformity. Because with the pressure on the head, there's been the lateral displacement of the epiphysis, and it produces a completely different concern for an analysis. At times, the condition may be bilateral, and it brings up the question whether an epiphyseal dysplasia or some other type of deformity or condition is present. At this stage, when the deformity is already present, then an arthrogram can at times be particularly helpful. An arthrogram may be helpful in the early phases, but it's been particularly helpful in this later stage to determine the degree of the involvement and distortion of the femoral head and maybe to some degree the acetabulum. As you look at this arthrogram, it shows that the head is flat, but that the acetabulum has essentially the same shape as the femoral head. It's important when an arthrogram is done to not just take an antero-posterior view, but to make different views so that one can see in which position the congruity between the femoral head and the acetabulum is the best. And it's apparent from this one that the only time that the femoral head has a reasonable contact with the acetabulum in a congruous way is when the leg is in the neutral position. Any forms of abduction, adduction, and even in the frog leg position shows that there's a very little contact between the femoral head and the acetabulum. And any type of procedure that might alter this may produce a more abnormal position than already exists. So one must be very careful in planning any type of reconstructive procedure that one does not decrease the contact between the femoral head and the acetabulum rather than improving it. One example of this is this child with a significant deformity, which on abduction view does not really go deeply into the acetabulum. An arthrogram was done which shows on abduction that there's very poor contact between the femoral head and the acetabulum. And then in spite of this, a varus osteotomy was done, which produced an adduction position of the leg, further shortening, and a most undesirable condition. And this is not a good way to do the whole thing. Reconstructive procedures in surgery can be considered when the head is not deeply inside the acetabulum, and on evaluation can show whether or not it will go back in, so that the abduction view, even on the plain X-ray, can be of value and may be all that's necessary, but desirably an arthrogram should be added to the same time. If the femoral head will go deeply inside the acetabulum, one should not immediately go to surgery. There is the risk that it will go back to its old position, as in the patient that I just showed you. So therefore, it is better to maintain the femoral head deeply inside the acetabulum for a period of weeks to be sure that it will maintain this position before moving on to surgery. And the Petri casts have been an excellent way to obtain this and maintain it for a number of weeks. Then one can proceed to the varus osteotomy and hold the femoral head deeply within the acetabulum. In a patient that has significant deformity and an alteration in the acetabulum as well as the femoral head, something on both sides of the joint may be needed. This is rarely indicated, but when a significant deformity has already occurred with deformity on both sides, then one should proceed to this. There are rare indications, it's a great deal of surgery, and it should be very infrequently used. It was done here with a reasonable result, but one can see that the epiphyseal line closed before the end of growth because the femoral neck is short and there's still some alteration in the femoral head. So a total analysis is necessary. And although this patient is better from this procedure, it is still well short of a very good result. Another problem has been that of hinge abduction, when there's been a significant deformity of the femoral head to such a degree that it blocks the abduction of the femoral head inside the acetabulum. And it is shown in here, where there is an arthrogram showing the femoral head flattened with a large bump out laterally. When an abduction is attempted, it levers the side of the femoral head out of the acetabulum and produces a large pool of dye where there's no longer contact between the femoral head and the acetabulum. This is a difficult problem, and anything in the way of the previous surgery outlined cannot be done because it will produce a more significant deformity than already exists. If on hinge abduction there's only a mild deformity and it is not as significant as the last one, as is shown here, a series of Petri casts or a period of traction and abduction may allow the femoral head to go back inside the acetabulum to allow remodeling in a plaster Paris cast for a period of time and may be subsequently followed with surgery. Another problem has been that of overgrowth of the greater trochanter. If there has been involvement of the epiphyseal line, and also if there's a major involvement in the height of the epiphysis, there may be a relative overgrowth of the trochanter, producing relative decrease in activity of the abductors. In the treatment of congenital dislocation of the hip, the arrest of the greater trochanter has been helpful at times to prevent this overgrowth of the trochanter. However, it has been of very little help and is rarely, if ever, indicated in the treatment of Perthes, because by the time the Perthes condition has reached the stage where this is obvious, it is too late, because any child that's over 7 or 8 years of age cannot really benefit enough from arrest of the greater trochanter to have the procedure done. If the child has such a significant deformity and the hip is locked in adduction that the previous procedures cannot be carried out, then some type of salvage procedure at times may be considered. At times a chelotomy, where a part of the femoral head is removed, can be considered. An example is this 5-year-old female who already has a very significant deformity of the femoral head with extrusion of a considerable portion of the femoral head well beyond the acetabulum. That it's impossible to place this femoral head deep within the acetabulum because of the deformity that's already occurred. One should not, however, resect this portion of the femoral head at this time. This portion is well ossified. The portion that remains inside the acetabulum is not. And if the lateral portion is resected, it will result in further extrusion and further deformity. One should wait till there's been more ossification of the portion inside the femoral head, even if one is to consider removing this part of the femoral head. This was done in this case. The patient at adult showed that the lateral portion was removed. The portion that remained is in contact with the acetabulum, and it is a procedure to be considered only as a salvage, because in this procedure one removes a large segment of cartilage and a section of bone on the lateral part of the femoral head, and it is not terribly desirable. If one could apply appropriate containment treatments early in the condition, this should be a very rare consideration. Another way is that if there is a lateral bump, instead of removing it, one can consider doing a valgus osteotomy, which will clear this part from the acetabulum and allow abduction. And this is probably a more desirable approach to the problem as long as the acetabulum is normal, to produce the valgus correction to clear it. However, even if there is a bump on the side of the femoral head, if the child can come out into 10 degrees of abduction, probably no treatment is indicated at that time. One other problem that comes in Perthes is that of osteochondritis dissecans. In most times, this is in the middle portion of the weight-bearing area. It shows mainly on X-ray, and in most cases, it causes no problems. If it's only an X-ray diagnosis, the patient should be left alone. On rare occasions, the fragment may free and fall into the lower part of the socket, and it can be removed. But this is the exception. Most times, this is really of very little concern to the patient and should be left alone. One should remember, however, before becoming too aggressive in the treatment of Perthes, that many of these patients do very well. Here's a patient of 65 years, although does not have a perfect result, still has a reasonably round head and has good contact with the acetabulum and has done very well over many of these years. And the experience has been that if the femoral head is reasonably round and reasonably fitting into the acetabulum, that they will do quite well. So one should think long and hard before carrying out massive reconstructive procedures on these young people just because of X-ray changes. So it would seem, in summary, that surgery can fall into two groups: as an alternate to bracing, where the patient will not go through the program and there's some social considerations. The second is the reconstructive phase, where something has already gone wrong and an effort is being made to realign something that's already deformed. This again should not happen very often with early and good care, but can at times be very helpful to the patient, but should be done only after a very complete analysis and being certain that better contact can be produced by the surgery than as it was before. So in conclusion, Jack, I would suggest that there are different patients, there are different groups, and it's very important to analyze each individual patient. And I think the most important aspect is very energetic treatment in the early phase of the condition. Regain the motion, maintain the motion, keep the femoral head contained by some type of rather simple bracing till one can make an analysis as to how severe the problem is. And I think most importantly, one can stop the treatment program much earlier than we used to think by the bracing method.
Dean, is the sex and age of onset of the patient with leg Perthes disease an important factor in determining the end result?
Yes, there is, Jack. There's a great difference between the young one and the older one with Perthes as a rule. However, some of the young ones, in spite of what's been thought at times, can have a very poor result. If they have a so-called cateral 4, where the total femoral head is involved, and especially if the epiphyseal line is involved, they will have a very bad result. So one cannot be too casual in treating the young one and must evaluate them and tell them the potential for bad result, especially if the total head is involved. At the other end of the spectrum, the people that are approaching adolescence that develop Perthes as a very late phenomenon usually have a very bad result if more than 50% of the head is involved, and are very difficult to treat, and are usually best treated more like with an arthroplasty type of approach of motion and very little surgery. Also, females tend to do less well than the males. It appears to be that the females are a bit older bone-wise and don't mature as late into adolescence to reestablish or change the deformity. So there is quite a difference in the ages and the sex.
When you're treating these children, Dean, how can you tell when to return them to normal activities, and how can you tell if you've returned them to activities too early?
Well, as I mentioned, Jack, we had the tendency to treat them too long in years past. And now once the dense bone or the sclerotic so-called bone is gone from the femoral head, even if there's large apparent holes or radiolucent areas, If the head is reasonably round and the motion is good, they can go back to weight bearing. The way to determine if they've started too early is if they start to lose motion. So I tend to return them by letting them walk around the house and do a little bit for a month or so, and then have them return to me and see if they've lost motion. If the motion is further restricted, or there's any change from what it was before, that becomes a sign to me that we've returned them too early.
Can you tell us if age determines the capability of the acetabulum and the femoral head to remodel in these children?
Well, as I mentioned, the involvement of the epiphyseal line is very important, because if they have no growth potential in the femoral head and neck, then they're going to do less well. Also, as we reviewed our patients, it became apparent that the younger they were when they finished the disease process, if their epiphyseal line was open, the better the end result, because they could tend to improve after they've gone through the process. So that seems to be the spin-off of the younger child having the problem, that they can grow and mature and develop and return close to normal, very similar to a couple of the patients I showed you in the talk.
Dean, how do you deal with a child who loses motion in the course of treatment?
Well, I think first of all they should be taken off their feet, because especially if they're in a brace and they've lost some motion, they're being forced into the brace, and this actually aggravates the problem. And if a child says they're having pain when they're in the brace, as a rule, this is because they've lost motion. So I remove them from the brace, get them back onto a bed rest type of phenomenon. As I mentioned, if they have only a mild loss of motion, many times they can be handled by taking the brace off for part of the time, mainly at night, and use home traction program.
After you've performed a reconstructive procedure on these children, Dean, is it still necessary to maintain containment of the femoral head and the acetabulum?
Well, at times after the reconstructive, the surgery itself has produced a good realignment, and that is what most people hope, but at times it has not, and they can stiffen. So if they stiffen up the same as if they were wearing a brace, then they should be put in traction and treated. And at times, even an abduction brace may be a little bit of help to get them started. I think there's been a tendency to think that the surgery was the be-all and the end-all, and many times they need to be treated a little more aggressively post-operatively and not just think that the surgery has done it itself. The other side effect of the surgery is that they limp for quite a long period of time, especially after a varus osteotomy. It's very important to tell this to the family beforehand and continue to evaluate the child and get them on an exercise program if they're late in recovering their abduction function.
Thank you, Dr. McEwen.